This is Selma Schimmel, and you are looking live at the great city of Chicago, which is once again playing host to the American Society of Clinical Oncology, ASCO. This is ASCO's 49th annual meeting, and this year's theme could not be more appropriate: Building Bridges to Conquer Cancer. More than 30,000 of the world's foremost cancer specialists are here, and so is the Group Room, making our 15th appearance at ASCO and one of our very best. Joining me now is Dr. Patrick Hugh, Melanoma Chair at the UT MD Anderson Cancer Center, our melanoma expert. Hello again.
Thanks, Selma, for having me here again.
There's a lot to talk about, and I'm just going to let you open up with what do you think is going on in melanoma, going from last year to this year, that is making an important impression for you and for the patient community?
Well, the field of melanoma therapeutics is moving very quickly, and it's exciting for all of us, for physicians and patients alike. There are two main ways we're treating melanoma. One is targeted therapies, in which we're trying to shut off the light switches that are flipped on, called mutations, that drive the tumor. And the other approach is immunologic agents, where we try to stimulate the body's immune system against the melanoma. And the exciting thing in the field is that both kinds of approaches are working well in melanoma.
And the idea of being able to mix molecular or targeted therapies in combination with immunologic agents, that's very innovative.
I think it's really the future, is to rationally put these targeted agents with immunologic agents. So we're still at the area of infancy in doing this, but it's going to be very exciting and going to be the future of our therapeutic approaches.
There have been 2 drugs approved by the FDA for the treatment of melanoma. Let's speak a little bit about that.
These drugs, dabrafenib and trametinib, block light switches mutations that are activated in melanoma cells. One of them is BRAF mutation, and the other one is the MEK. It blocks MEK. Those are, you can think of them as different light switches in the same electrical pathway that turns on the tumor cell. And when both of them are blocked, it works even better than either one by itself.
How do you identify these pathways?
The patients who have a mutation in their BRAF gene in the tumor are the ones who respond to these agents. And so the tumor needs to be sequenced. The DNA from the tumor needs to be sequenced to see if they have a mutation in that BRAF gene.
What are we learning about melanoma that we can take away and apply to other solid tumors?
For example, we can apply multiple ways to stimulate the body's immune system, and that tends to work better than just one way. And so at this ASCO meeting, there will be a presentation to talk about combining blockade of the PD-1 brake as well as the CTLA-4 brake. They're 2 different brakes on immune cells, and when you block both of those brakes, it works better than either one by itself.
Dr. Hu, why is it that we've had such challenges in the area of immunologic therapies for cancers in general? So much hope, because the theory is, it makes so much sense, but it's challenging to bring these compounds to success, but yet we have seen success in melanoma. Why has it been easier with this disease type versus other cancer types?
We don't really know the answer to it. Why does melanoma tend to respond to immune manipulation compared to other tumor types? It's been a question for many years that we've tried to think about. One hypothesis that we have is that there are more mutations in melanomas because the UV rays of the sun cause mutations in the DNA, and these mutations are seen as foreign to the immune system. So the immune system is very good at getting rid of foreign things like bacteria and viruses. And so when there's a new mutation, it looks like a bacteria or virus to the immune system. And so that is one potential reason that melanomas have a lot of mutations. But guess what other cancer has a lot of mutations? Squamous cell lung cancer in smokers. that the cigarette smoke causes a lot of mutations, and so that tumor type also has a lot of mutations, and so that may be one of the reasons why lung cancer also is responding to some of these immune manipulations.
Dr. Hu, based on where we are from this ASCO to where you see the goals for the new year in oncology until the next meeting, where are we going, and what should we be watching for now in the ongoing research that we already have for melanoma?
Well, in my opinion, we have some good results from this ASCO and previous and recent publications that you can combine targeted agents together and get better results compared to single agents. And there's a suggestion from this ASCO that you can combine immunologic agents and get better results than the single agents. Now, that's a suggestion because the study was not randomized, but it's a strong suggestion. And so I think now, going forward, what we must do is start to combine these two silos of activity in targeted therapies and immunologic therapies. We must start putting them together in a rational way.
So when you go back to your institution and you're in your lab, is this going to be the focus of your work?
It is 90% of what I'm working on, is how to put the targeted therapy together with the immunologic agent. Because some targeted therapies might suppress the immune system, and we need to know about that because we obviously don't want to combine those.
Exactly.
And so I think doing that in a rational way is important. It is really what I'm working on in modeling that in mouse modeling systems and in vitro systems and clinical trials.
Thank you very, very much for spending time with us at this ASCO. Dr. Patrick Hu, Melanoma Chair at the UT MD Anderson Cancer Center in Houston, Texas. Thank you.
Thank you.